Welcome to the Vet Dental Show. I'm Brett Beckman. I'm a board-certified veterinary dentist, and we come to you every week on Wednesday to provide the veterinarian and the technician team some actionable things that you can use in your practice. And this episode is going to be a recorded episode that we've done in the past, not a podcast that we've recorded or not the Vet Dental Show, but actually some other information for you that we know you're going to enjoy. So sit back, enjoy, and we'll see you at the end of the podcast.
Do you find giving oral Cerenia ahead of time helpful at all when cost of injectable is a concern? In our practice, that's not feasible just because we're referral only. That's certainly something that could be done in a general practice if that is a way to help, relieve some of that cost. Certainly doable. However you want to tweak that and make that easier and better for the owner, absolutely. Just doesn't work in our practice because we're not there. From Emma, do you always recommend taking out retained deciduous teeth? What age would you wait before taking them out? Would you recommend doing it while the patient is under for the spay and neuter? Yeah, anytime we have two teeth occupying the same space. So if we got a deciduous tooth that's there and we can see the adult is partially erupted or fully erupted, yeah, that deciduous tooth has got to go. And so the sooner the better. And so if that's happening at the spay and neuter, absolutely. We never want to have two teeth occupying the same space at the same time. Presurgical blood work. What is the protocol? Depends on the patient, the age of the patient, and the status of the patient. So a standard patient under the age of 4, CBC chemistry. Over the age of 7, I think we start to add in a T4 and urinalysis. If there's any abnormal heart murmur or arrhythmias, abnormal EKG, we're going to want to have an echo, at the very least chest x-ray. So it really depends on the patient status that we base our presurgical workup and blood work. How do we manage to keep patients light without them chewing the tube? Obviously, if they're chewing, they're too light, and we ventilate. We turn up the ISO a little bit and ventilate them until we get them to that level of anesthesia. And again, this is kind of a learning curve, learning what that plane of anesthesia looks like. From Cindy, you stated you generally keep patients light enough to have palpebral. I'm curious how you ensure you won't be inadvertently bitten. Again, we're looking for that palpebral, but we're also looking at, when we move that patient or if the patient's moving themselves, obviously that's a trigger. We need to get them a little deeper. So we get them to the point where they're no longer moving, but they still have that palpebral. So, how many breaths does that take? It just depends. So we're watching that patient and looking at the heart rate. If we see that the heart rate kind of shoots up, maybe that patient's feeling something, we have to repeat the block. Or Dr. Beckman will let me know as he's doing oral surgery, hey, this patient is starting to move its tongue or it's getting too light. And so that kind of communication from my doctor as well. But it is a learning curve. So when I'm taking my dental x-rays, and you'll see when we do the x-ray portion of this, how we position that pet and what I'm looking for before I place that sensor inside the mouth so that doesn't get bitten, so that my patient isn't too light where my sensor is going to get damaged. So there's a lot of parameters that we look for, and if we have any of those, movement, biting, swallowing, we're going to ventilate and stop what we're doing and ventilate and get them back to where we need them as far as their anesthetic plane. The dosing for Midazolam from Riley, yes, 0.1 mg per kg for cats as well. From Riley, again, with only one technician in the dental monitoring and cleaning, how would you manage getting to phone owners as well? Would this not increase their anesthetic time? I am almost always wearing AirPods or some type of Bluetooth where I am hands-free. So I can still be with the patient and still talk to the owner via phone. And so we are using our technology in order to allow us to do that. Now, I do have the luxury of an anesthesia technician, so I've got somebody in the room, but sometimes there isn't. And so I am in the room as much as possible by using as much technology as I can, and my Bluetooth helps me to do that. So I'm usually cleaning teeth, or I'm looking at x-rays, or I'm doing something and talking to an owner at the same time. So it allows me to multitask but still be present in that surgery suite. My doctor tends to want to scale and polish first, then chart, and then take rads. Cindy, good question. And again, couple of issues with doing it in this order. Number one, we need to get the diagnosis first. In order to get that estimate and that owner permission as quickly as possible following induction, so that we can complete that case appropriately. Cleaning teeth before we do the assessment is counterproductive because we don't know what teeth are going to be extracted, and there is absolutely no reason to clean a tooth that's going to be extracted, and it is wasted anesthesia time. That is inefficient in completing this case in as short a time as possible by cleaning first and then assessing. You need to talk to your doc and let them know that your continuing education that you're attending with dental experts, Dr. Brett Beckman and myself. The order needs to be different in order to assess appropriately, keep the anesthesia time as short as possible, be as efficient as possible, have to get the diagnosis first, and then move on from there. The scaling and polishing sometimes doesn't happen until after oral surgery. If there's advanced disease in there and a lot of those teeth are going to be extracted, I'm not going to do anything until oral surgery is completed, because I'm going to wait until all of that is cleaned out of there and that we can have all of that disease and infection kind of out of there. And if there's only a few teeth that need to be cleaned and polished, I'll do that at the end. Oral surgery will go first if your doctor's available. If not, then we're going to clean those teeth and move forward from there. But if we've got the owner's permission at the outset, then we can complete that case however it can be completed as efficiently as possible, depending on if your doctor's available or not, and move that case forward so that we're making sure that something's happening with that patient at all times. For general practice, from Becky, do you have any pointers, best practices for scheduling dental cleanings? We do dental cleanings daily, but oftentimes there's only time for cleaning and assessment. This is a really good question, and I'm glad that you got this out here. Dr. Beckman and I recommend, as you're learning and creating your dental department and learning all of these techniques and establishing protocols, we recommend no more than 3 patients to start. And there's just no way of knowing what we're going to find when we're doing that assessment. And so we allow for 3 patients. And obviously, we don't want to have 3 12-year-old Yorkies on the same day. That's a pretty full day. We'll want to kind of evaluate maybe a 2-year-old Labrador Retriever, in addition to, a 6 or a 7-year-old smaller breed. But no more than 3 patients a day. Once you become comfortable with the protocols and completing these cases as this workshop is laid out, and you're finding that you're becoming more efficient, then you can start to gradually add cases. So as your time taking dental x-rays decreases, your time putting an estimate together decreases, getting that assessment done and the chart done, that time decreases. Now you've got more time to complete oral surgery, and so now you've got time maybe to add a patient to that schedule. And that happens over time and can vary from practice to practice. So we recommend to start with 3, and then depending on how your efficiency level is, your timing, move on from there. Alrighty. A few more questions here. From Carissa, should preanesthetic blood work be mandatory for all patients and be included in the initial quote? Again, our preanesthetic workups are done ahead of time, but absolutely preanesthetic blood work. Absolutely, no question. Regardless of age. We instituted preanesthetic blood work at a general practice years and years and years ago for all spays and neuters. Anybody having anesthesia would get preanesthetic blood work. And at least 2 to 5 times a week, somebody was going home without having the procedure done because we discovered maybe a liver shunt or kidney issues in a young dog. So age does not, automatically clear them for anesthesia. That preanesthetic blood work assesses them and essentially will clear them or not clear them for anesthesia. So absolutely mandatory for all patients. What's the best way to get uninterested staff to support the clinic time dedicated to proper dentals? Yeah, this is another instance where you're going to have folks in the practice that don't want anything to do with dentistry. And so we typically will have our dental technician talk to clients only, not all the technicians in the hospital, for a number of reasons. All of that information, if we've got many technicians answering questions or talking to clients, that information can get very diluted. It can get turned around and be incorrect. And so we'll start to get inconsistencies in answering some of these questions with clients, or inconsistency in these conversations. And if a client talks to more than one staff member and gets different answers to the same question, that breeds a lot of mistrust. And so then we have a client compliance issue where they may not move forward, because if they get different answers, they're not 100% sure that you guys know that you're on the same page and where you're going. So a dental technician, a dedicated dental technician to talk to these folks is a good solution to avoid all of that and to do the correct recommendations and have much better client compliance with a confident, knowledgeable dental technician. Do we have any book modules you'd recommend for quick reference for pathology diagnosis? We do have courses that Dr. Beckman's got a webinar, radiographic interpretation, absolutely helpful, and all of the courses, his oral surgery courses, talk about pathology diagnosis and treatment. So definitely you'd want to visit our website, veterinarydentistry.net, and certainly take advantage of all of that.
I trust you enjoyed that episode. We enjoyed providing it. If you would, do us a big favor and go to our iTunes page, post a rating and review, and take a picture of that with your cell phone, and then post it on our Facebook page, and we'll send you the Instrument Use Essentials course. If you also look below, there is a link to 2 live trainings that we do. And one is on radiographic interpretation, the other is on killer tips for quicker extractions. If you have not been to those, register for the one that's coming up next, and the link will be in the show notes on the website, the Vet Dental Show, and we'll get you in and get you a 30-minute, 40-minute overview of those topics that are really insightful and all take home. And then we'll also give you an opportunity to get a great deal and some bonuses on those 2 courses that are online courses that span 5 hours and 7 hours. So hopefully you enjoyed this episode. Hopefully you'll help us out with the post on our Facebook group. And then as a little extra bonus for you, you've got that link down there. You can register if you haven't been to either one of those and enjoy all of that content that we're going to give you on those 2 topics. So take care. We'll see you next week.